Thank you, Rachel, for the introduction and to the group for having me back. So this is an extension of the talk that I gave 2 weeks ago. And today we're going to talk about some additional uses for cell-free fetal DNA technology. I have no conflicts to declare, and the discussion of labs that I'll talk about today is based on my own personal clinical experience. So to review, non-invasive prenatal screening, or NIPS, or NIPT, as some will call it, is the most sensitive and specific screening test for common aneuploidies with the lowest false positive rate, and the only screening tool that will interrogate sex chromosome abnormalities. It can be performed as early as 9 to 10 weeks. It is not diagnostic, so any positive result does recommend confirmation through a diagnostic procedure. And as a reminder, based on the performance of NIPS, it is recommended by ACOG, ACMG, and International Prenatal Diagnosis Society to be offered to all women in pregnancy, regardless of their aneuploidy risk. Because we are looking at placental cells that are undergoing programmed cell death, this screening test relies on the amount of those cells, what we call the fetal fraction, in the maternal sample in order for us to get a result. So in the previous talk, we reviewed NIPS as a screening tool for common aneuploidies, including trisomies 21, 13, 18, as well as the sex chromosome abnormalities. So, to review, why does it matter if a chromosome is extra or missing? That's because each chromosome has hundreds of genes on it, and any extra or missing genetic material can disrupt fetal development. If we look a little bit closer at a chromosome, there are areas within chromosomes that we say are gene rich. So the chromosome pair here in the middle shows regions of genes, and those regions are labeled A through D. So when a pregnancy has a congenital anomaly detected, we will always consider a microarray analysis to be able to detect if there are missing or extra pieces of chromosome material. So rather than an entire chromosome being duplicated or extra, we're actually looking for regions or pieces of that chromosome to be deleted or duplicated. So if you see on the left-hand side, one pair of the chromosomes has a deletion of region C, and the chromosome on the right-hand side has a duplication of region C. We call these copy number variants. You may also hear them called microdeletions or microduplications. And the best way to test for these copy number variants is through a microarray analysis. And a microarray is only performed on a diagnostic testing sample. So chorionic villi, amniocytes, or peripheral blood, as well as other tissues. But my point is, anytime we have a birth defect or a congenital anomaly, doing a prenatal diagnosis with a microarray is really the best, most comprehensive test. However, as I'm going to talk about in the next couple of slides, non-invasive prenatal screening does have an option for expanded testing to include some of these copy number variants. So not all of our patients, as we all know, are comfortable with prenatal diagnosis. So there is a test called maternity genome, and that is an offering through LabCorp that does screen for 23 whole chromosome abnormalities. So thinking back to standard NIPS that we talked about last time, that's only looking at 5 chromosomes, 13, 18, 21, X, and Y. Expanded NIPS looks at the other 18 chromosomes. So it's screening to see if there's a trisomy or a monosomy, but it's also screening for those copy number variants. So it can pick up deletions or duplications if they are large enough. So they have to be greater than 7 megabases or 7 million base pairs. This is not a diagnostic test, as a reminder. So there is also an option for this test to do a reflex, meaning if a standard NIPS was ordered through LabCorp, and if that patient were to have ultrasound findings down the road, we can ask the lab to reflex to the maternity genome option, where they actually reanalyze the retained sample for the rest of the chromosomes as well as for those copy number variants. Any positive result really should be confirmed with a microarray, as I mentioned before. So when would we consider using this test? If there are non-specific findings on ultrasound, so those findings that are outside what you think about being, a trisomy 13 with holoprosencephaly, or a Down syndrome with an AV canal defect, things that are non-specific. If you have an isolated cleft lip, or if you have a megacystis. So something that is not fitting a typical clinical picture, you could consider a maternity genome for those patients that are not comfortable doing a prenatal diagnosis. There's another scenario as well, is that families who have translocations. So if a mom or a dad are carriers of a chromosomal rearrangement, we know that whenever balanced translocation or a balanced arrangement is passed on to offspring, there is that opportunity there through that transmission for that rearrangement to become unbalanced. And when it's unbalanced, it leads to a deletion of one chromosome and a duplication of another. In situations where these rearrangements are large enough, maternity genome could also be considered there. The other spot to use this type of testing is if you have families that have had issues before, previous children affected with, maybe not necessarily a genetic disorder that this is testing for, but something that just makes them highly anxious in a pregnancy, where they don't want to do any sort of invasive testing. They're fearful of that risk, but they really want just to know as much as they possibly can. This could also be a consideration. Limitations of the expanded option are very similar to the standard NIPS. Again, it's not interrogating all chromosome material. It's only looking for copy number variants that are large. So it's not looking for those, micro deletions or micro duplications that are less than those 7 megabases. And so there is a residual risk, like with all screening tests, and the positive predictive value for this particular screening option is difficult to calculate because the incidence of these copy number variants are pretty low in our population. So a PPV is not always a reliable tool to use when counseling a patient on a positive result for these copy number variants. And like standard NIPS, of course, it's not looking for neural tube defects because it's not quantifying maternal serum AFP. And then any positive result could be from the fetus, but it could also be representative of the mom, of placental mosaicism, fetal mosaicism, or a vanished twin. Okay, so now I'm going to move away from chromosome abnormalities and focus a little bit on single gene disorders. And these are the genetic causes for about 10% or up to 10% of birth defects. So here we have another karyotype or image of a chromosome analysis. But I want us to focus now rather on just the entire chromosome or even regions of the chromosomes like we were looking at. We really need to hone in now on the gene level. So as I mentioned before, each chromosome has hundreds and hundreds of genes, and our chromosomes are numbered 1 through 22. We call those our autosomes. And then our X and Y chromosomes are, of course, our sex chromosomes. These chromosomes are numbered because of, the genes are on different chromosomes. So we need to be able to track and identify different regions of genes. And because chromosomes are all in pairs, we have 2 copies of every gene. So one from mom and one from dad. And ideally, both of our genes are working and do not have a mutation or variant that would prevent the body from reading that genetic instruction. When there is a variant or a mutation, and I will use those words interchangeably, that can then disrupt the translation of that gene into a protein. And if that protein is disrupted in the body, that's when disease occurs. So to provide a little bit of context for the rest of our talk, I want to briefly go over some common inheritance patterns for single gene disorders. We also call these monogenic disorders. So here on the slide is autosomal dominant inheritance. This is when a genetic change resides on an autosome, so on one of those chromosomes 1 through 22, and theoretically would affect males and females equally. So with an autosomal dominant pattern, only one gene is required to have a genetic change for the disease to manifest and for that individual to be affected. So if a parent is affected with an autosomal dominant condition, each of their children have that 50% chance of inheriting that genetic change, since it's that flip of a coin that they're going to pass down the chromosome with the genetic change, passing it down through either egg or sperm. With autosomal recessive inheritance, both copies of a gene must be changed or mutated in an individual for them to manifest symptoms and to be affected. So if we see here on the bottom right with our affected individual represented by the 2 red slashes, that individual had to inherit both of those genetic changes from their parents. So in other words, both parents have to be carriers for the genetic disorder in order for there to be a risk to offspring. So when an individual is a carrier, they are unaffected, and they're unaffected because they have one working gene copy, which is enough to keep them healthy. But when you have 2 carrier parents, they have that 25% chance of having an affected child, 50% chance for having carrier child, and another 25% chance for having an unaffected non-carrier child. This third inheritance pattern, I just want to briefly go over, is X-linked. So X-linked is when we have a mother being a carrier and she has a genetic change on one of her X chromosomes. For X-linked inheritance, when a mother is a carrier, she has a 50% chance of having an affected son, and that being mothers has a 50-50 chance of which X she passes along to that son. And then men, because they're only passing their Y chromosome onto their son, there's never any transmission of an X-linked disease between father and son. So only will it be from mother to son in this case. So 50% chance for an affected son and a 50% chance for a carrier daughter when the mother is a carrier. Okay, so now that we have some of those definitions in our minds, I want to talk about single gene non-invasive prenatal screening. And there are 2 types of single gene non-invasive prenatal screenings that are commercially available right now. The first we're going to talk about is Natera has a test called Vistara. And this is a cell-free fetal DNA option for screening for autosomal dominant conditions. And the performance of this test is really dependent on the specific gene that it's interrogating. So there's not really a global specificity or sensitivity. It does depend on what gene is being identified. So the gene list that's been curated is based on a few factors. So there are approximately 30 genes spanning about 25 conditions. And the genes that they chose are those that have a really high rate of what we call de novo mutations. So that means these are new mutations that occur in the gene. They have not been passed down by a parent, but the child actually has the single gene disorder because it occurred as a new genetic change at conception. So again, not inherited, but a de novo or new genetic change. So that's one factor when they put this list together. The second factor was that many of these conditions present with later onset ultrasound findings. So generally the 3rd trimester, some of these don't have ultrasound findings at all, and others are pretty non-specific. So considerations for using this test. The first consideration would be advanced paternal age. So, we hear a lot about advanced maternal age being 35 and over, and that's really for the risk for chromosome abnormalities or an entire extra or missing chromosome. The risk here is not for chromosome problems, but it's for single gene disorders, and that's due to replication errors that occur in spermatogenesis over a male's lifetime. So we say when a man is 45 and over, he is defined as advanced paternal age. And the genes that are included on this panel are fairly large. So The larger the gene, the more room there is for error to occur. And they're associated with about a twofold increased risk for these point mutations or these DNA replication errors that are occurring. A twofold risk may sound high, but when you consider how rare some of these disorders are, the chance for one of these to actually occur is still less than 1%, but significantly, again, elevated just based on dad being 45 and over. So that's one consideration if you have a patient whose father of the pregnancy is over 45 and they are, wanting to know everything. Vistara might be a good option for them. Another consideration would be if there is a family history, but only could you do it if it's a paternal family history. Again, NIPS is looking at maternal DNA as well as the fetal DNA, so you can't do it if the mom is affected. But if there is a paternal family history of a genetic disorder, Noonan syndrome is a good example because it has variable expression, meaning the father may be, mildly affected, but still wanting to know if there's an increased risk for things like pulmonic stenosis or other, cystic hygroma, which is another thing we see for Noonan, that this might be an option. So let's see. Okay, and then lastly, if there are late gestation anomalies and the patient is not, interested in pursuing prenatal diagnosis, this would be another consideration. So about 1/3 of the disorders on here are craniosynostosis conditions or premature closure of the sutures in the cranium. And then also skeletal dysplasias. Some of those are lethal. So the Natafork dysplasia is on there. So again, you might not see evidence of these types of genetic disorders until later in gestation, where a patient may not want to pursue a prenatal diagnosis, but still want some information for preparedness ahead of delivery of that baby. The second single gene NIPS that's commercially available is something called Unity. It's offered by a lab called Billion to One, and it is focusing on autosomal recessive conditions, and it is screening 4 genes. So the genes, variants in the HBB gene cause sickle cell disease, beta thalassemia, or other beta globinopathies. Variants in HBA cause alpha thalassemia. CFTR causes cystic fibrosis, and SMN1 causes spinal muscular atrophy. This test is set up in 2 steps. So the first step is the mother herself actually undergoes carrier screening to see if she's a carrier for one of these disorders. If she is found to be a carrier, the test then reflexes to the second step, which is the single gene NIPS for the fetal risk assessment. A paternal sample is not needed for this type of testing. And the test is only going to provide a risk assessment for an affected fetus. It's not going to predict a carrier status for that fetus. So some considerations here. Of course, if your patient is a known carrier for one of these 4 conditions and her partner is unavailable for screening to determine if there is a reproductive risk, this would be a nice option. If there is an at-risk couple where both parents are carriers for one of these conditions and there is that 25% risk for an affected baby, but they don't want to pursue prenatal diagnosis, again, this might be a nice option. One limitation here is that the residual risk of a screen negative result can be difficult to interpret. And that's because of the way the lab quantifies or counts these genetic variants or genotypes for the moms and the dad. So it can be a little bit difficult to interpret that residual risk. So I would say for any of you that are considering using this, to, of course, rely on a genetic counseling to assist with some of that interpretation because it can get a little bit in the weeds. Okay, so a little bit about genetic carrier screening before we get into our case. A carrier is an individual who is heterozygous for a pathogenic or likely pathogenic variant in an autosomal recessive or an X-linked gene. And a pathogenic or a likely pathogenic variant, these are mutations within a gene that are known to cause disease. And that's important for our case later. So carriers for autosomal recessive conditions typically do not manifest symptoms themselves. There are a few exceptions to that. And carriers for X-linked conditions, because it's a mother who is carrying it, sometimes they can manifest differently than their offspring. So women have something called X inactivation, where one of the X chromosomes preferentially silences genetic or abnormal changes. And that preferential silencing is not always consistent. And so some women may manifest while others may not. Preconception screening for carrier screening is, of course, the ideal time to be doing this. Of course, recognizing that a lot of people don't get picked up until they are currently pregnant. Keep in mind, if you have a family that is consanguineous, these individuals are at increased risk for autosomal recessive conditions. And then a really important point here is that carrier screening does not report variants of uncertain significance. And a variant of uncertain significance is a mutation within a gene that does not have enough evidence to classify it as disease-causing or normal. So ACOG, they are not pointed in their recommendation on panel size. So some of you may know that carrier screening comes in all different shapes and sizes. Some carrier screens test for just cystic fibrosis, spinal muscular atrophy, and the hemoglobinopathies, like the Unity screen that I just went over. Others will test for, up to 500 diseases. So the ACOG has really kind of left it up to clinics to develop their own consistency and protocol in terms of panel size. I encourage practitioners to consider the carrier frequencies for guidance. In our practice here, we're usually thinking about if the conditions are, less than 1 in 100, meaning if a person has a less or a greater than 1 in 100 chance of being a carrier for this disorder, that might be something to consider testing them for. ACOG does say that all patients at minimum should be offered screening for CF, SMA, and hemoglobinopathies, keeping in mind that you would want to do a CBC with a hemoglobin electrophoresis if you're trying to capture the thalassemias. Negative carrier screening reduces the chance to be a carrier, but it does not eliminate it. And for anyone that's identified to be a carrier, their reproductive partner should be offered screening. And then consider genetic counseling referral if you do have a consanguineous couple, if you have an at-risk couple, or if you have a family history of a genetic disorder, in which case a prenatal diagnosis is likely a better option. So I believe